Okay. Hello and welcome. Let me try and turn on my video. Just a moment. Go. Okay. All right then. Hello.
Hi.
Hi. Okay, I hope that you can hear me and that you can see my screen.
Yes, Meena.
Perfect. Thank you very much for joining me today. So, welcome to today's webinar. My name is Mina Niknazemi. I am a dentist working in Cologne and also an OccluSense consultant. And I'm happy to share some of my experiences and also an insight into the world of digital occlusion with OccluSense today. First and foremost, a couple of words about the company Bausch. Bausch was established back in 1953 by Dr. Hans Bausch, who himself was a dentist, and he developed the articulating paper with progressive color transfer in 1953 because he was aware of the importance of the masticatory forces and their effect on occlusion. And if we think about occlusion and the definition, we see that it's any contact between the teeth of the upper and the lower jaw. So any restoration, for example, fillings or crowns, may mean an intervention in this system. Okay. And that's where OccluSense comes into play. So OccluSense, as I mentioned earlier, is occlusion in a digitalized manner. And if we think about the concept of occlusion and the definition, and take a moment to visualize the main aspects during static as well as dynamic occlusion, and think about how we currently test this on our patients. We know that the current standard involves standard articulating paper in different shapes. You have pre-cut strips, you have occlusion paper covering the full dental arch, and you have occlusion paper rolled and ready to be cut in sizes as you wish. And obviously the different colors in with various thicknesses, and the standard foil being 8 microns thin. Currently, the standard to check occlusion in all dimensions is primarily done using different colors. So here you can see red being used for static occlusion, black for protrusion, green to leave mediotrusion markings, and blue for the other way around, green for laterotrusion and blue for mediotrusion markings. And as we all know, this is a very, very time-consuming matter, especially if you have to repeat the process a couple of times. And that's where OccluSense comes into play. It's occlusion in a digitalized manner where you use a wireless handheld, an electronic pressure sensor, and you can place this in the patient's mouth and record any movement that you want. As you can see in this visualization, there's an asymmetric design of the sensor where the pins of the handheld that go into the holes of the sensor can only be inserted the correct way around. So once this is clicked in and you've closed your handheld, you can then insert this sensor into your patient's mouth and ask them to conduct any movement that you want to have conducted. Here we see the OccluSense visualization and also the red color markings left on the patient's teeth. And for those of you who don't own an OccluSense system yet, I'm going to quickly take you through how this works. So the set consists of the OccluSense handheld that you saw previously as well. You need an iPad with the OccluSense iPad app. This is available to be downloaded for free on the Apple Store. as well as the sensors, which are available in 2 different sizes. So currently we have X and XL, and these sensors differ in width rather than length. They're highly sensitive and are able to detect 256 different pressure levels. They still remain only 60 microns thin, and yet still provide very good flexibility to be inserted in the different patients' mouth openings. And one, to me, very extremely important factor, they preserve a red color coating, which leaves the markings in your patient's mouth as you conduct the movements, just as we know this from standard papers and foils. So how does OccluSense work? To get started, you need to initially set up your system, and you need to ensure that your iPad is connected to a Wi-Fi connection. You then go onto the OccluSense app, and then you can start your initial setup. You only do this once, right at the beginning, just to set up the handheld, and you will then be guided through every necessary step. As you see, it wants to a couple of allowances to connect to your device, and then the setup will be prompted automatically. And then you're ready to register your system. So you need to introduce your handheld to
Open
your
your
iPad.
OccluSense iPad app, tap on menu item Settings, then choose Handheld Registration. Fill in the registration form. Please enter country, name, first name, street, zip code, city, and your email address. Tap the Register button to send your registration data. A confirmation email will be sent to your email address. Open the email and press the Confirm button. If your registration was successful, a green tick will be displayed.
So this is just a little summary of the registration of the system.
To initiate the sensor test of the handheld has to be connected to the app first. Now go to Settings in the OccluSense iPad app. Having your handheld and the test sensor ready. Now tap on Functionality Test Handheld. You will now be asked to insert the test sensor correctly and to close the sensor flap. The pink-colored control button to start the function test. The function test starts now. The result of the function test is displayed in the app. Now, remove the test sensor from the handheld and put it back in the storage box.
This sensor test you don't have to do before every single use. I just wanted to show you a brief video of this, so you have seen how to conduct it. It's very quick and easy. You insert the test sensor, so that green thing, similar to the normal measuring sensors, into the handheld, and then you conduct the test, and within a couple of seconds, your handheld will be calibrated to ensure that the pressure recordings that you conduct each time have a good accuracy. Okay, so the standard way of testing occlusion on our patients has worked for many years and has not been changed for very long either. So why do we really need an OccluSense? Because, I mean, never change a winning horse. I want you to take a look at this diagram. So if we compare the current standards, the papers and foils, with occlusion measurement with OccluSense, you can see in this diagram that in order to get from checkpoint 1, which is the very initial contact on antagonizing teeth, through to checkpoint 2, which is the pathway between initial contact and the maximum intercuspal position, through to checkpoint 3, the maximum intercuspal position, you would have to continuously monitor this pathway from point 1 up until point 3 for an exact understanding of the 3-dimensional process. In this scenario, when you're using occlusion foils or papers as a control measurement on your patients, you will only be able to see what happened at point 3. So in this case, you have a snapshot of one single moment in time. It's similar to taking a picture of one moment. With OccluSense, however, if you look at the same diagram, you have the opportunity to look into this process at any given moment in time. And as occlusion as a whole does not only consist of the final jaw position, but also every movement that's happening in between, you are able to now take a video recording over time rather than just a single snapshot. But do we really need that much in-depth information for every single treatment? If we take an implant as an example, we know that the threshold for tactile sensitivity of an implanted construction is much higher, about 8 times than the threshold of vital teeth within their natural periodont. So any occlusal interferences, as for example, a construction that is slightly too high, they won't present themselves on the implant as they would on vital teeth. The symptoms will be different. And any disbalance within the system can lead to functional disorders. And there may be plenty of other indications whereby an OccluSense can aid in better and more precise diagnosis making. So you have the opportunity to detect hidden or interference contacts quite quickly. You can look at early periodontal damage due to incorrect loading. You can look at the force distribution throughout the entire dental arch, as well as avoid chipping due to incorrect balancing, and record dynamic occlusion on splints. What you are also able to do is compare recordings over time. So if you've got a reading from 6 months ago, you can take that reading and record it after 6 months of splint therapy and record and compare the occlusion over time. What you can also do is record orthodontic changes and look at any occlusal movements. What you're automatically doing is documenting and using it for patient education. To get started with the system, you can add a patient to the database just like you would in any other CRM system. So here you press the add button that you see on the left-hand side, and then you're able to fill in all the blanks with the patient's details. What you can also do is use the patient number that you have in your own dental practice CRM system so that you are able to trace back that patient individually using the number. You fill in the blanks, and once you've then added your patient to the database, you are able to activate them. Here we've used the patient that had already been added to the system, and you can also see their recordings, their past recordings. You can scroll down, go on to new recording, and now you're ready to start a new recording. It will prompt you to adjust the time and the frequency of the recording. So for how many seconds do you want to record? How frequent are the pictures that are being taken? And once you have selected those, you can start. Using the green button before the recording, you can also select the time and frequency. So you don't have to do this via iPad. You can also do it via the handheld. In this live demonstration, you can see how the sensor is inserted, slightly bent into the patient's mouth. Obtrugate can be used as an optional, gives you a clearer view. And then the patient can conduct any movement. Here you see static occlusion, the movement in the patient's mouth, as well as the analog OccluSense reading. And here we're conducting a couple of movements that you ideally practice with your patient beforehand, because having that much stuff in their mouth and around it, it's quite irritating. So if you practice it before, most of them will be able to comply. As mentioned previously, the markings are left on your patient's teeth. So any adjustments that you want to be doing, they can be done immediately after you have recorded your occlusion. You should also be aware that the recording will start automatically as soon as the sensor detects a pressure change. So it's not as soon as you press the button, but the pressure change will indicate for the recording to start. Alternatively, if you start a pink button again, if you press it again, then you can start manually recording. And for more options such as live and recording, you can read it up in our instructions for use manual, which I would recommend to have a read through before using the OccluSense handheld. As you saw on the readings before, there are different colors and columns in the OccluSense reading, which I want to touch base on with you now. So what the colors tell you more about is the pressure that is being applied and the size of the contact points. Green represents an area of contact on a wider surface, whilst orange displays something in between, green and red is a punctual contact. If you now look at the load of this bridge that is being transferred onto these two pillars in order to try and understand what these columns and colors really mean, you can see that the left pillar has a much wider surface contact to the ground, which is characterized by green columns. The right pillar, however, has a punctual contact surface to the ground, which is why this is characterized with red. The height of the columns display the difference in pressure change compared to their surrounding points. So that's why the height is the same, because the amount of pressure that is being applied is the same. However, the contact surface to the ground is different, hence the different colors. Here we have another example where you can see that small pressure changes are being observed between the green columns, intermediate pressure change at orange, and highest pressure change at red. To transfer this knowledge onto the three-dimensional movement during mastication, we can try and imagine that a person is standing on a plate covered with needles barefoot. And if you think about the amount of pressure that is being applied to the sole of the foot of this person by each and every single needle, and you now take a little outburst from this needle plate and compare how much pressure activation you can see on each needle, then if you take two needles to, if you take two neighboring needles that are receiving pressure, whereby the pressure change is very, very high between these two needles, we know that one of those needles is being pressured down quite heavily. So this is a punctual contact if the neighboring contacts have less pressure. So with OccluSense readings, you have to always remember that they are not absolute pressure changes that are being given to you, but relative. So all of the pixels on the sensor are constantly being compared to neighboring pixels on the same sensor. Those pixels are the same as the needles. If you have neighboring needles that have roughly the same pressure being applied, we know we have a wide contact surface that is being activated. So that's why this would be green, small pressure changes between the neighborhood needles. If you have a large pressure change, then you have red, because we have punctual contacts here. Therefore, red columns indicate high spots, they indicate initial contacts, and standalone contacts that are not in full intercuspidation. Whilst green indicates a low pressure change. So this would be the case for planar contacts on, for example, abrasive teeth or adjacent contacts with similar pressure. Red in this case is only a color, so I want you to always keep in the back of your mind, red does not mean alert, alert, you have to do something. If this is what you are looking for and it's a natural occlusion that is signified by red, then it's absolutely fine. It's simply a color in this case and means we have a punctual contact here. And I will repeat this again because it's really important. The contacts are constantly being compared to their neighbors. So this is a relative pressure change that you are able to detect. If we now take a look at this occlusion or OccluSense reading for static occlusion and try and analyze this together, we can see that in the right molar region at the back, there are no red columns. This does not mean you don't have any pressure there. In fact, if you look at the pressure scalings, so the pressure distribution that is noted by the percentages around those scalings, you will see that actually the highest pressure within the entire dental arch, so 23 and 21%, is located right there. What this tells you is that there are no standalone contacts with high pressure changes compared to their neighbors. However, the contact surfaces, they're planar, but the amount of pressure that is being applied in this area is higher overall compared to the other areas. And the same level of detail you are able to deduct from readings with dynamic occlusion. So you can see lateral movements to the left-hand side here, and then to the right-hand side over there. And any occlusal interferences, as you see in the left molar region here for lateral protrusion right, you are able to detect very, very clearly. Some features that I personally find really, really helpful include the viewing options. So you are able to amend between a two-dimensional view, which you see here, and this gives you an indication of the percentages, and the three-dimensional view, which you can see here. This gives you more indication about the height of the columns. You can also combine this view, so you can see both. And here again, the full OccluSense screen that you would see when you are looking at recordings from your patient. So you can go and amend the viewing options. You have the possibility to time, pause, rewind, fast forward, do whatever you want. You can do some noise cancelling. So sometimes 256 pressure levels are quite a lot, and maybe you only want to see what's really important. You can take a look at more percentiles, quartiles, and as mentioned at the beginning of the webinar, compare recordings over time, which might be quite useful for splint therapy and occlusion measurements. Here you can see how the filter, so the noise cancelling, works if you are using less pressure levels in your viewing. And another quite useful tool is the exportation of data. So in order to export any file, whether this is only a screenshot of your OccluSense reading, or you want to export the video that you are watching, so the occlusion over time, you always have to enter your full screen mode. Only when you are in full screen mode, the export button will appear, which you then tap, and then are prompted to either download your formats in PNG or PDF. This will be accordingly saved to your files or your Photos app. And for the video, it's roughly the same. One quite nice trick, if you press screen recording and your microphone is enabled, you can add speaking comments onto your video. You can also amend the viewing option using your finger if you want to maybe put some more focus on certain areas of the reading. And this will also be recorded within your video so that you can draw back to that information and the thoughts that you have in the future. The network access guide you can also download online for more information. And in order to now transfer all of this knowledge onto the patient's teeth, we need to follow a couple of simple steps. So you need to ensure that your midline in your patient's mouth is also the midline on the sensor. And once you've ensured this, you're able to track back every single mark in the patient's mouth according to the segments on the iPad app reading, as you can see in the black lines and the arches. So looking at this reading as well as the clinical view, you can see that the blue circle indicates a regular occlusion on a molar. Looking at the orange circle, we see regular occlusion on a premolar. And when we now look at purple, we see a premature contact. How do I know this? If you look on the very right and the middle, the OccluSense readings, you can see that in the three-dimensional view, the height of the columns are pretty much similar. However, if you look in the middle view, you can see that again, 50% of my entire pressure is located in the left molar region. So this immediately is an indication of an unbalanced force that is happening here. And if I now take a look back into my patient's mouth, so in the clinical view, I can see that actually the buccal contact on tooth 36 is not a contact that I want there. So this is my premature contact. And the first indication of this was the orange quadrant. So you immediately see that something is not right there. And the same you can do for dynamic occlusion as well. You see here a non-balanced group guidance with most of the pressure being located in the bottom right quartile and a single contralateral contact antagonizing this movement. And the same can be done with protrusion. There's a few clinical cases that I have prepared for you today. These are not only my own, there's also a few other clinical specialists that were kind enough to share their work with me. So case number one, we have a female patient. She presented herself with ringing in the ear, the feeling of absorbent cotton, cervical spine with ligament sheath prolapse. She also had a hyperactive thyroid gland and some muscle tension in her face between nose and ear. So this is her initial symptomatic. Looking at her occlusion or her static occlusion with OccluSense, we see a primary pre-contact on 48, unequal loading in intercuspal position, and some final heavy loading between 41 and 45. Protrusion showed parafunctionality on 48 again. Medial protrusion to the left, no canine guidance, parafunctionality on 48 again. And to the right-hand side, we see group guidance, but again, parafunctionality on 48 and 38. Her brachial movements were mainly conducted over 43, with again, parafunctionality on 48. And looking at her nocturnal movements showed us that actually in centric position, 48 had a premature contact, and changing her occlusion in a very slight way by taking out this premature contact on 48 actually led to a great improvement of her symptomatic that she presented herself with right at the beginning. We don't always need a dysfunctionality in order to whip out the OccluSense and look at our patient's occlusion in a digitalized manner. So we can also use it for our normal standard dental checkups, especially if we have some prosthodontics with, for example, root canal treatments or implants in a situation. So over here, we've looked at this patient's occlusion with OccluSense. You can see that in the right molar region, there is actually no pressure, but this is normal because we don't have any antagonizing teeth in the fourth quadrant, so there's no pressure change being detected here. But we see quite well, her occlusion is very much balanced. So the pressure that is being obtained in every area is very similar. So this is something good. The same can be done for dynamic movement. So lateral protrusion to the left showed beautiful canine guidance. And protrusion over here. The final example I've got for you today consists of OccluSense and splint therapy, and how you can adjust your splint in a highly accurate manner to improve the treatment plan. So if you take a look at the condylar processes of on the right and the left-hand side of this patient, we see very different shapes and forms, and this is actually a case of hemimandibular hyperplasia. According to the differing development of the condyles, this patient suffers from CMD, whereby the occlusal interferences lead to teeth grinding, and especially at night. And since the patient chose no surgical intervention, the primary treatment involves preservative symptom management, whereby a night guard is fitted to protect her teeth and her joints. If we take a look at the static occlusion without the night guard, so this is a very normal occlusion in a natural habitat, and take a look particularly at the occlusal interferences and disbalances, as well as the force distribution, we can see that she has an open bite on the left-hand side to begin with. And as the contacts slide into the right place, the bite advances and more contacts are gained. This is actually easier to be seen if we rewind back. So this is the beginning of the static movement. And as you can see, there's only contacts in the right molar area, whereby here we have an open bite. We can see this very clearly here, the open bite on the left-hand side and the occlusion seen here. Right, so if you think about what you currently do when you are fitting a splint, what we do is we conduct a shim stop protocol, and when this is evened out, we let the patient go and get them to come back in a couple of weeks for a checkup. We did this with this patient. We did a shim stop protocol. We had roughly the same amount of resistance everywhere we pulled it out. And she came back after 2 weeks with pain in her jaw and her joints. And we then took OccluSense to look at her occlusion with the splint. And this is what we saw. Okay. If you remember the diagram that I showed you earlier with the car and the journey from 1 to 3, if we check occlusion with shim stop, for example, and go somewhere here. So we have a snapshot of a single moment in time, roughly at the end, so the final jaw position. And this might be a bad example. I think it was somewhere here, right? Okay. So this is her static occlusion when we're doing the shim stop protocol. And if you see, there's contacts everywhere. So wherever you insert the shim stock foil, you will receive some resistance. That's what you see with shim stock. But looking at this occlusion with OccluSense, you realize that what is happening before is actually an unbalanced occlusion, with most of the pressure being applied in this area. And as the bite advances, we gain a little more stability, but it's still not 100% balanced out. And the same checks can be done for dynamic occlusion as well. We did a Michigan splint over here, where this also had to be fabricated further. In order to gain a full canine guidance. Here you can see protrusion. Again, this had to be fabricated further. Okay, so maybe the most relevant question for today, does articulating paper replace does OccluSense replace articulating paper and foils? It really depends on the indication. So with foils and papers, you have the opportunity to take a single snapshot in time of one single moment. And with OccluSense, you have the ability to take a video recording over time. And it gives you a more detailed overview. And depending on what you are looking for within your treatment plan, one does not take the place of the other. But my recommended algorithm would be to use OccluSense before and after. So you use it initially to check for any premature contacts and look at the pressure distribution. You can then do your fine adjustment with papers and foils and check your results with OccluSense again. What you're automatically doing as well is you're documenting everything. And this may not be too bad in the forensic sense of things. We have experts all over the world who have kindly shared their feedback with us. So OccluSense is currently being used in not only Germany, but also in Turkey, in France, in Spain, in Brazil, all over the world, actually, for different indications. So whether we have functional experts, prosthodontics, implant prosthetics, you can use OccluSense in every single dental substitute. To get started, I'm going to summarize again. You need an Apple iPad. The versions after 2014 are supported. You need an app which you can download for free on the Apple Store in different languages. You need a Wi-Fi connection and the OccluSense system DK5000, which will provide you with everything you need. So you have a conductive charging station where you can put your handheld on for it to be charged. You have a test sensor. You have sensors to get started with, and instructions for use manual, and a little box to keep your gadget in. Thank you very much for your time and your attention today. Feel free to note down my email address if you have any questions in the future regarding the use of OccluSense. Feel free to drop me an email or connect via LinkedIn by scanning this QR code. And other than that, I'm happy to answer any questions that may have arisen during the webinar.
Thank you, Meena. I have a couple of questions.
Yes.
So, I mean, I understand that there is a difference between OccluSense and the other T-scan. The T-scan is just a pressure indicator, while OccluSense is a pressure indicator with transfer of the points onto the teeth. The question would be is, since it is a transferable material, is it that this particular sensor is to be used only once for that particular patient, or can the same sensor be used for all the movements as long as you don't have any punctures in the sensor?
It's a very good question. You can use the same sensor on the same patient multiple times. So the color coding has been developed in a way whereby the sensor is, we've conducted 12 measurements with one sensor on the same patient. Obviously, it's not sterilizable because it's an electronic device. The sensor has electronic pixels in it, so we can't sterilize it. Therefore, it's not usable on other patients, but the same sensor can certainly be used multiple times on the same patient.
So the color transfer is, because once the color transfer is done, what I understand is probably there wouldn't be enough color to be transferred to the next bud. Am I correct, or is it how is it possible? Like, for example, when you use an articulating paper, once you have the patient biting on the teeth, the color transfer happens, and then if you try to use the same paper again, because typically we end up putting in the same place, there wouldn't be any color to be further transferred. So how does that happen in OccluSense sensors?
In theory, you're absolutely right. Practically, you would have to really insert the sensor in exactly the same position as you did before for the color to be gone in exactly that area. And actually, the color on the sensors is so shifted. It's put on in a way whereby you are able to use it multiple times.
Okay. I get the point. Okay. Then you were also talking about the I would say the dynamic functional contacts. So is there a protocol wherein you start with static and then you ask the patient to do it protrusive? And I mean, is it step by step, or do you do all the movements at one go? And how does it? Like you do a static bite. From the other point which I wanted to ask you is, to get the first contact, do you deprogram your patient and get the first contact, or how do you do that?
To be honest, I like to split it up because I find that the patients usually find it harder to conduct everything as I instruct them to do behind at once. I think it's harder, and my recordings will be longer because then there'll be quite a few seconds within my reading which are not precise. So when I do static occlusion, I ask them to bite a couple of times, and once I'm sure that this should be roughly the correct bite, I get them to bite like that again a couple of times, and then I tag that recording as my static occlusion. And then I go into the dynamic occlusion, and depending on the patient's concordance, so if it's really easy for them and they're able to conduct the guidance really easily, and this has not happened many times, but then I get them to do it within one recording. However, most of the patients have functional impairments, and conducting the movements for them is really hard. And because I want my recordings to be really precise and not have that much error in them, I ask them to conduct the movement to one side a couple of times. Once I'm happy with their movement, I get them to do it with OccluSense. And then I tag my recording again, lateral protrusion to the left, and then we do lateral protrusion to the right, and then protrusion.
Okay, thank you. I think that answers most of my questions. And you said the sensor along with the color paper, the size is about 60 microns, right?
Yes.
Okay, so that's very good. And I mean, in your experience, do you see most of these papers, I mean, these sensors, do they get punctured? Or do you have any tips and tricks where, sometimes you lose your sensors because of the, the point contacts, which you are talking as red contacts, where the surface area of your contact point is very less, and that actually punctures your sensor. So what do you do in your clinical practice to avoid this, or how do you go about it?
If the sensor is punctured, definitely don't use it anymore. You can't really avoid it, and after some wear and tear, so by try 12, the probability is very high that the sensor will get punctured and you will have to use a new one. But for the beginning, it's really hard to get them punctured. They're very stable, so you really have to try to puncture them.
Okay. And around the red thing, there's a white thing which goes in, which is a part of the sensor. Is it a paper, or is it a plastic, or what is it actually?
Can you repeat that question again,
Yeah,
please?
I mean, what I was trying to understand, the sensor has a red area and then there's a white area, right? And the white area has a part which goes into the holder. So my question was, is that white area, what I see, is it made up of paper or is it a plastic material?
It's paper. Some parts of the sensor have a little bit of plastic foil, just so it's waterproof because of saliva, but it's mostly paper.
Okay. Okay. Yeah, because why I was asking this T scan, the sensor holder is a plastic holder, and I do find sometimes patients, it comes into the movement interference. So,
Yeah.
so that's exactly what I wanted to know. And as you said, there are two sizes. One is the regular size, and the other one is XL, and which is basically to do with the width of the sensor, right?
Yeah. So it's only the mouth opening.
Okay. Yeah. Okay, and there is you also said that the midlines have to be coincided so that the area of incisors and premolars and molars is automatically it's calibrated in the software. I mean, it looks up into the widths, so there isn't any specific adjustment like in T-scan. If you can give the mesiodistal dimensions of the teeth, automatically because you actually have to, in T-scan, what happens is there is no pressure indicator. I mean, there's a pressure sensor, there's no pressure indicator. So what happens is when we use a paper, sometimes matching up the spot of where the highness is there. In articulating paper, it might just be on the adjacent surface of the tooth, while probably on the computer it shows slightly more mesial. I mean, it sometimes happens. It's not always, but then since this has both pressure indicator as well as pressure sensor, probably I think understanding the interpretation becomes more easier. I guess the clinical interpretation becomes more easier because the transfer is happening immediately as the pressure is being sensed. I think that helps. And the other question I had was, have you ever tried to use them for pediatric patients?
Unfortunately not, no.
Okay.
It might be interesting. I feel like children may find it nice to see, so it's something that they may work with, but I have never tried it, no.
Thank you, Meena. I think since I have your email, in case I have any further doubts, I think I would write to you.
Absolutely, feel free. Thank you
Thank
very
you once
much
again.
for joining me today and your time, and I hope that you have been able to gain a little insight on the introduction of OccluSense. And yes, as you said already, feel free to drop me an email if you have anything in the future.
Thank you. Have a
Thank you very
great day.
much. Have a
And
good
have a
day.
good weekend.
Bye.
Bye.